So I think we can start right now. And then at maybe 11:30, this is when our scheduled break, and that's when we can take our next break. So the next part of today's, let's say, workshop or talk is the blood product transfusion in critical care setting. So we have a lot of, let's say, we talk about whole blood, we're talking about blood products, and sometimes people tell me, are these considered to be drugs or not? And I would consider that similar to fluids, similar to IVIG, similar to clotting factor products, PCC. All of these are things that we all experience in different settings, and blood products is one of the things that you want to also be well versed in. So the blood products that we're going to talk about, I'm going to be focusing on packed RBCs, platelets, fresh frozen plasma, and cryo. I don't have to talk about the details of each one of them because I'm sure you already know that. I don't know if you are or had the chance to see these blood products and how they are supplied or available, how to order them, who needs to be involved, where do they come from, if they're stored in your unit, if there's a process to order them, who would be involved in all of these processes, and what are the things that you want to consider when you give these agents. Obviously, another part that I'm not going to be talking about that much is how much to order. For example, 1 unit, 2 units, 3 units of each one, and how to order is not something, but this is just a typical guide in terms of the different types of units, how much of volume, and what do their impact be on the different lab values. I talked a little bit about PCC earlier on. We talked about the certain clotting factors that it could contain. We talked about having or being, let's say, concentrate with clotting factors 2, 8, 9, and 10. We talked about having let's say heparin, as well as protein C and S. I'm not going to talk about albumin, just for the sake of completeness. I just included it here as a volume expander sometimes. Recombinant activated factor 7, I'm also not going to be talking about that within my talk today. So the blood product administration is going to be tailored on a lot of scenarios, the patient's clinical factor, whether the patient is bleeding or not, whether the patient has a surgery to be performed or not. We also think about blood products in terms of the different lab values, hemoglobin, INR, platelet counts, and all that. And then we also need to focus on the risk factors that are associated with these blood transfusions, because that's the reason why we tend not to want to give blood products all the time, is because of these risk factors. Now, can you just jump in and tell me what are the potential risk factors that could be associated with blood transfusions? What? Yes, yes. What else? That's the easy one.
Infection.
Allergic reactions, yeah. How about volume overload? Right, that's a big one.
Right.
Yes, exactly. So we talk about Trali, we talk about taco, you've heard that. And then there are the simple things that you also want to monitor. For example, the fever, the hives, the chills, the hypotension, dyspnea. Are they leading to significant type of effects or not? All of these are things that we have to
one thing that maybe not common ones of physicians, the shortage in the
Yes,
because
we don't have that.
It's a human resource. So
It is, and you want to make sure that you're using it for the most needed type of patient.
especially with the platelet that comes in.
Yes, and I think there's a lot. Yes, and the issue, and the reason why I wanted to talk about this here today is because that was one of the reasons, is that every institution and every department thinks that they are the one that needs it the most. And there's not a universal way of saying, okay, you meet this criteria, we'll give it to you from the blood bank. You don't meet this criteria, you shouldn't be actually thinking of it. It's not something that's really available widely, so we want to use it wisely as well. That's why I wanted to really talk about, just because we say that it's fresh frozen plasma, let's give it to all our patients. maybe it's not really necessary or needed. It will save us a lot in terms of the resource, and it also prevents the type of reactions that we're worried about.
There is
We
massive
need time to prepare also, because it's frozen, we need a thawing
Yes,
process before
yes.
giving directly.
Yes,
And the physician requested, now I want it, okay, we need a process of thawing before giving the.
yes, and I've heard a lot of stories about people wanting blood products, but they're demanding it to be a quick process, and they say, we have a fridge in this unit, why can't you just keep it there and we can take care of it? And why is it a long process? I've heard so many stories. For example, in the emergency, you never see it being given because by the time the patient is already in the OR or some other places. So yes, that's definitely something that we have to consider. Having it ready and prepared, and that whole process is going to be, it's going to take time in a patient that really needs it the most at the quickest time. Because when we think about blood transfusion, we know that there's something critical that we need it for. Okay. So we're looking into the clinical scenarios, we're looking into the labs, we're looking into the hemodynamics, tissue oxygenation, all that. We don't necessarily only rely on hemoglobin, for example, but there is a lot of talk and discussion that we're going to have today about the thresholds for the different indications within the critical care settings. So the decision to transfuse a patient in the critical care setting or any hospitalized patient is usually, according to, as we said, the clinical judgment, the patient-specific factor that ultimately guide our decision, but also we need to look into evidence-based threshold so that we can at least reduce that variation that we can see within practice. So just before I start, when I say evidence-based, actually I think I have a slide where I'm going to ask you that question, so we can read it for later. We talked about the complications that are associated, the transfusion complication, volume overload, immunomodulation effect, and that transfusing too early can expose the patient to these unnecessary risks. And then the thresholds are not going to be the same for all the drug products. And really, when we talk about the clinical purpose, that's when we want to indicate it. For example, if we're thinking about increasing oxygen delivery, that's going to be where we want the RBCs. If we're thinking about platelets, that's when we want to prevent bleeding. If we want to replace clotting factors, we think about fresh frozen plasma. So really, we look into the whole context. It's not only whole blood product, or we want a certain type of component for a certain reason. And then there's always that talk, should we be restrictive into our transfusion, or should we be liberal or permissive and give everyone based on what we think is necessary? And what I mean by restrictive or liberal in terms of, let's say, red blood cells, looking at hemoglobin, should I target or should I transfuse when the patient has a hemoglobin of 7 to 8 versus should I transfuse when the patient has a hemoglobin of 8.5 to 10? And I'm sure most of you would say it depends, right? And we're going to look into the evidence around that as well. So what is your institution's current threshold for transfusing blood products? For example, what are your targets? Let's say we can start with hemoglobin. Does anyone follow a certain target or a threshold? Or knows a threshold in the back of there that guides them to replace?
Yes, below 7.
Yeah, we tend to say 7. Do you know where that 7 came from? Why 7?
There is two structures.
Yeah, we could say that there's studies that compared, let's say, should we replace it when it's below 7 or below, let's say, 9 or 10?
Two structures.
Yes, and within, let's say, very briefly, I'm going to talk about that in details, but very briefly, let's say they said 7 and then 10, and then we see is there a difference in mortality? That's what we do in most of our studies, right? But why did they choose 7? Why 7 and 10? Why 7 and 8? Why not 6 and 10, for example?
Less complications.
No, not really. To be honest, if you look into the history, or you look into and get a deep dive on why 7 was chosen, because we're going to talk about 7 a lot, it was a lucky number. If you go to and go back, they just chose, and let's look into it, 7 and 8. It was a lucky number that they chose. So there's no basis. But that started, and then we continue to do our research about different conditions and different scenarios and the need for blood transfusion based on that.
start with the duration of 57.
Oh, you think so? That's a good thought process. Okay, how about platelets? I heard people say 50, 10.
For active bleeding, 50.
For active bleeding, 50. I like that answer, because if it was not active bleeding and it's 50,
It would be 30 to 1, 3 to
10, yes, okay. So I like that. So when you see a 50 of platelets, do you request blood products?
Yeah, but there is CNS bleeding. This is really,
We'll talk about that,
so
yes.
this is a different scenario.
Yes, okay. So this slide is just generally, I want to see within, let's say if you work in a critical care setting, do you have targets other than the indication? Do you think about 50, 10? Does the number make sense to you? Does the number have a meaning that guides your decision? How about fibrinogen levels? Do you tend to measure fibrinogen in certain cases? Do you have a threshold where you want it to be increased or not?
For substance, the IC, we need it to be between 1.5 to 2.
Okay, so because this is your area of specialty, so you're thinking about it more than others. And you know when to request it, for example, DIC or certain cases. Okay, how about the rest of you? Do you request it? Do you think about it? Do you want it into a certain level, similar to, let's say, platelets or hemoglobin? Okay, I don't hear answers. How about PT values? When the patient is not on, let's say, heparin or heparin, do you have threshold?
We don't put that.
How about INR?
1.5.
Okay, I hear 1.5. When you see 1.5 INR, you think, oh, let me give something, maybe. Or what is it, liver impairment? Is it what's inducing? You think at 1.5. See, everyone has it differently. Maybe someone else would think, okay, it's 1.2 and I want to think. Someone would say 2.5, I want to think. But see, everyone thinks about numbers, especially when you want to take action. Okay? So that's what I want to say from this slide. We all think about numbers sometimes. In addition to the clinical context, we've all learned somewhere that we worry about INR when it's 1.5. We worry about fibrinogen in this situation. This is what I want to ask about it. We worry about platelets. Okay, I want to stop heparin. I want to, okay, is there active bleeding or not? What is the indication for all of this? We think about so many things when we talk about blood transfusion. So within the next slides, we'll talk about this in more details. I want to start with fresh frozen plasma. Usually in critical care, we think about fresh frozen plasma either as prophylactically, for example, should we consider, these are questions, I'm just putting them there and then we'll talk about them separately. Should we consider transfusing of fresh frozen plasma prophylactically in a patient that's non-bleeding and does not need a surgery? No, okay, and we'll talk. The other question is pre-surgery prophylaxis. Do you want to give it because you know that the patient is going to go for a planned surgery, they're not bleeding, should I give fresh frozen plasma? Depends on the case, and we'll talk about that. Okay, and I hear no's, I hear depends on the case, I hear okay, procedure, I want to think about that. Nice. The third thing is therapeutic, if there is a, not prophylactically, now, the patient is actively bleeding, okay? Should I think about it? Okay, in which case scenarios should I be more worried? How much should I give? Yes, okay. So the first one, prophylactically, it should be avoided according to the literature as well. We don't usually give it if the patient is not bleeding and not planned for a procedure, similar to what you mentioned. Then, prophylactically in a patient that has planned. I heard a yes, I heard a no, I heard it depends on the situation. If we want to go back and look at the evidence, it actually is conflicting whether we should give fresh frozen plasma before surgery or not. There's a multiple RCTs that have failed, a lot of studies actually we looked into, they failed to find clear mortality benefit in patients that have been given fresh frozen plasma before a planned surgery. There was, within the guidelines, because I looked into a lot of the guidelines, they looked into INR greater than 2.5. This is one they found more benefit, and there were studies that say it would be 1.5. So there's a lot of diversity if you look into certain guidelines and documents. There's a lot of documentation and a lot of unclear and a lot of debate about the evidence on whether we should give it or not.
Most of the studies become with the chronic liver disease patients.
I try to avoid those types. I try to avoid
Because
those
most
type.
common, most
Yes,
common use.
exactly, yes. I try to avoid them when I look into that, because they have a separate wording. Yeah, okay. So what I'm trying to say is that I heard that answer even before we talked about the evidence, that some people would think about it before procedure and some of them would not, okay? And some of them would think, oh, if an INR greater than 1.5, maybe before a procedure I want to give it. Or if it's 2.5, now I want to give it. So this is just summarizing what's out there. Of course, as we mentioned earlier on, when we talk about all of this, it's really just to give you an idea where you want to expand and read more or be curious or change in your practice. Because sometimes what we do is we rely on certain things. For example, we see the whole context, we see the whole overall, oh, maybe I'll give or not give. But right now, as we mentioned, this is a resource. We don't have that much. So at least we want to be smart about when we want to prescribe it or order it. Then we have a patient that's actively bleeding. And the recommendation is that we do definitely give that, especially if there's coagulopathy in this. If we have DIC, we would give it. If we have severe bleeding, we would give it. If we have hepatic bleeding, we would give it. So these are the situations that we have, even within group. Okay, now coming about cryo. Do you prescribe or recommend cryoprecipitant? When would you do that? Because you already know, do you know from where cryoprecipitant comes from? So usually you have fresh frozen plasma. Oh, and there was another question before I start cryoprecipitant. Fresh frozen plasma. Why do we call it fresh frozen? Why do we call it fresh? Why can't we just say plasma? Why can't we just say frozen plasma? Why fresh frozen plasma?
The clotting factors are inactive.
We just say FFP. Why do we say that? I mean, you know.
The process in the Safi.
Yeah, okay. It's within 8 hours of collecting blood that we get the fresh frozen of the plasma, and that's when we call it fresh, because we want to reserve the clotting factors themselves. Okay, so if it wasn't within 8 hours, if it was, let's say, between 24 and 8 hours, it would be just frozen plasma, not fresh frozen. Now, if you have cryoprecipitant right now, from where do you get it? From fresh frozen plasma. Okay, you're removing the liquid out of it, and the precipitant, the one that remains, that has the clotting factor, is what is cryo. Okay, so we want to know, because now we know that it has the clotting factors, and you generally give it and think about it when you talk about fibrinogen, but when do you want to recommend it, is the question. Active bleeding, yes or no? Okay. Is any active bleeding something that you don't require, right? So there are certain indications why you want to. I have the answer in here, right? So DIC, for example, as well as liver disease, for example. And then if you do get a level, over here I have them in milligram per deciliter. I heard different units, okay? What I have over here was based on a certain guideline that said if it was less than 150 milligrams per deciliter of fibrinogen, a patient with liver disease, this is when I want to replace it with cryo. If a patient has DIC, fibrinogen less than 100, this is when I want to. And look into your resources or references and see, but know exactly when do you want. Not because you think a DIC case is here is when I just want to order it. And when you see a fibrinogen level, what guides you or what number guides you to request it. And I don't want to be fixed with some certain number because everyone uses their own guidelines. It's just the idea of knowing when you want to order it. Okay. The normal value, according to milligram per deciliter, is 200 to 400. You can get fibrinogen or you can increase it either from fresh frozen plasma or from cryo. And then I have a few questions. Trauma-induced bleeding, what do you do in that case? Would you give cryo or not? And I want to talk about the massive transfusion protocol, but would you think about cryo or fibrinogen supplementation as well or not? These are just questions that I want you to have in mind. And then what's your hospital? I want to hear from you. What's your hospital protocol? for using
We can
fibrin.
go on muscle transfusion protocol.
CBU.
We're going to talk, I want to ask a very important question about massive transfusion, but in terms of fibrogen supplementation, do you have a certain rule that you follow yourself or a certain rule or guideline that you follow for you to consider?
Two guidelines in hospital, the muscle transfusion and blood product management. So we have the threshold or target for each case and what product to use and what is the dose.
That guideline, is it an institution or something related to your specialty, right?
An institution.
In your institution. Great, this is what I want to know. Other hospitals, do you have, you're in Ahmedi, and you follow one?
I created.
See, I knew that, because, and then every hospital should have their own as well. Okay, so that's something, if you don't know, you should ask about it. Okay? Okay, platelet transfusion. When would you want to give platelets? Let's say thrombocytopenia. No bleeding. Less than 10. Certainly, I would say less than 10.
Without fever.
Without fever, I like that.
Because with fever it's usually more than 20.
Yes.
With
Okay.
active bleeding, more than.
Yes, so also there's a guide.
Yeah,
I could
with
see.
CNS, more than 100 or within 80 to 100.
Exactly.
This is the service.
Exactly. There's a lot, if you want to dig into all of this, you're going to see that there are studies to talk about, these are the certain criteria, this is when I want to replace or give platelets, okay? For this, and so I can go to the next slide, thrombocytopenia in general, when would you define a platelet that the patient has thrombocytopenia? What level? Do you follow the same thing, less than 150 or less than 100?
100.
Okay, I hear 100, some say 150.
It's according to the guidelines.
And see, so everyone has a different, okay? The thing is, you're looking into not only one value, you're looking also into trends sometimes, you're looking into what medication the patient, for example, is on, what the patient's condition has, any comorbidities or anything that could lead to low platelets as well. But in general, ICU patients, we see it all the time, it's very common in that
We have a
population.
patient on antiplatelets, regardless of the platelet count, we give platelet transfusion with the active bleeding.
Yes, and that's why we talked about platelets as one of the reversing things that we would do. Yes, absolutely, yes. Okay, so this is something very common that we would see, and it's actually linked to high mortality when you have low platelet levels.
There is one issue also with the platelet counts and the patient with a chronic kidney disease or urine platelet that will have the effect of dysfunction in the platelet regardless of the number also. Same
Yes.
as the,
Yes.
on antiplatelet, so we give platelet transfusion if they have active bleeding regardless of their counts.
Yes, yes. I didn't want to look into those specific cases. I just wanted to say in ICU in general, but you're absolutely right. There's a lot of guidance and we don't just see numbers. That's the point takeaway. We don't treat numbers. We treat the whole context itself. In the ICU, I know that thrombocytopenia can occur because the patient has a lot of invasive catheters, multi-organ dysfunction, DIC, might be on ECMO, drug-induced, heparin-induced, for example. There's a lot of reason you want to think about when you talk about thrombocytopenia. If you look into the guidelines, the AED or the British Hematology Society, prophylactic platelet transfusion is recommended when it's 10 or below, and that's without any type of fever. We talked about a condition if there's fever or anything else. Expert opinions and clinical practice is what actually guides it. So if you go and look deeper into their recommendation to see, where does it come from? Is it high level, let's say, recommendation or not? You'd see that there is really limited RCTs, and we just do it by practice. We recommend it less than 10. So I wouldn't be surprised by someone seeing a patient not less than 10, not bleeding, not fever, but still would think about platelet transfusion. I like this table a lot because it has the two different types of guidelines, and then the procedure that the patient is going to have, and then when do I actually want to replace platelets based on the different type of procedures. So I really like this. This really guides me, because if it was just a central venous line that you're going to do, and the patient has a value of less than 20, this is another reason why you want to give platelets. So it's not less than 10, the usual. These are certain things that can actually guide the transfusion as well, so more reasons. And then, of course, we cannot talk about, now let's talk about red blood
Just
cell.
something to add about the platelets. Sometimes we use an agent to correct the platelet count rather than giving platelet transfusion, which are the thrombopoietin agonist, thrombopoietin receptor agonist, like romignostim injections or the tablet Revolade or avatrombopag to increase the platelet count if we have time to correct the platelet count before procedures also.
I love that thing. I didn't include that over here, but I think a lot of us maybe we're not even well versed about these options that are available. I try to limit the options right now to these things, but definitely it's an area of worth exploring, and I feel everyone should actually know what's available and what could be done other than blood transfusions. Absolutely. Okay, now talking about red blood cell transfusion, so we can't start a discussion or talk about this without referring to the TRIC trial of 1999. That is a randomized control trial, looked into the different transfusion, because we're going to talk about those thresholds, the 7 versus 10. So this is the most popular or landmark trial about RBC transfusion. So this is where they looked into, well, is there a difference if I replaced RBCs for patients that have a hemoglobin less than 10 versus a patient that has a hemoglobin less than 7, and they looked into 30-day mortality and other ICU and hospital mortality as well, and they found that there was no significant difference between correcting, let's say, RBCs if the hemoglobin was less than 7 or 7 or less, or 10 or less. And that's why we tend to, because we want to avoid the side effects, we avoid the risk factors. So when it's 10 or 7, this is when we would think about replacing it with RBCs. There was no difference in mortality, and at the same time, there was lower mortality in patients, if you see the subgroup analysis, in younger patients or patients that had severe or severely ill patients. I'm not going to go and look into the outcomes over here. And then if you want to look into the guidelines, I have a few that we're going to share today. So the first one is the American Association of Blood Banks, or the AABB International Guideline of 2023. They talk about red blood cell transfusions in different case scenarios and different situations. And then there is a recent one from September 2024. In the Chest Journal, it's the American College of Chest Physician Guidelines. They talk about red blood cell transfusion specifically in the critically ill adult. And I think today I wanted to go over the evidence and the consensus guidelines or recommendations that came out of this. They included 22 RCTs and cohort studies. They made 2 strong recommendations and 4 conditional recommendations. The quality of evidence range between low and moderate. And so for today, when we look about RBCs in the critical care, we tend to look into different subgroups. For example, is it just anemia associated with critical illness? Is there acute gastrointestinal bleeding? How about in the case of septic and septic shock? Should I be replaced in different threshold? Acute coronary syndrome, TBI, active hemorrhage, or massive hemorrhage. And in all these situations over here, do I have an active or a non-active bleed? So when would I basically recommend RBCs? So in anemia, in critically ill patients with just anemia, hemoglobin of 7 or below 7, and a patient that is hemodynamically stable in the ICU without evidence of active bleeding, so a non-bleeding patient, this is when I would recommend, or that's what they would recommend, replacing red blood cells. Higher thresholds is indicated when there are other types of indications, and we'll talk a little bit about that. If we look into that guideline that I just referred to, the Chest 2024, they talk about whether we should give restrictive or permissible or more liberal, meaning should we give it at 7 or below, or they have higher recommendations where they would recommend RBC transfusions, and their recommendation was really to go with the restrictive of a below 7. And the recommendation over here was a strong recommendation with moderate certainty of evidence. If you look into acute gastrointestinal bleeding, according to this 2024 chest review, in critically ill patients with acute GI bleeding, we recommend a restrictive over a permissible type of transfusion. Again, another strong recommendation. So we still use the restrictive one over here. How about in sepsis and septic shock? Should we replace it? If, in general rule, RBC is not routinely recommended unless the hemoglobin is less than 7. As I look into the chest guideline, or let's say the chest review, in patient with septic or end organ hypoperfusion, we suggest, not recommend, against adding a permissible or a liberal RBC threshold to the usual care. So we still stick to that. If I look into the survival sepsis campaign guidelines of 2021, they also say that RBC transfusion is only suggested when hemoglobin concentration is below 7, and the target when you do replace it is to keep the hemoglobin between 7 and 9. Higher target is sometimes warranted in specific scenarios, MI, for example, severe hypoxia or acute hemorrhage, we'll talk a little bit about that. Their strength of recommendation was a weak one, just for you to know, and the quality of evidence is low. Looking into the TRIST trial, which is another landmark trial that talks about transfusion requirements in septic shock patients specifically. In this RCT, they also reviewed the below 7 or below 9 threshold, and they found that there's also no difference in 90-day mortality, and fewer blood transfusion were obviously seen in the restricted group. This is why we still stick to the less than 7 or 7, less than 7, let's say, cutoff for transfusion of RBCs. Acute coronary syndrome. So now we see a difference over here. Transfusion may be considered in a patient with ACS and they have a hemoglobin of 8 or 9. So if it's 9, if it's 8, maybe this is when I would think about transfusion up to 7 in this case, only because of their ongoing ischemia and hemodynamic instability and their need for that to compromise for their condition. If you look into the CHEST 2024, they suggest against a restrictive, unlike the other type of recommendation, so they would go with a more liberal, meaning if it's below 9 or 8. Okay? A restrictive approach, according to the evidence, in this population specifically, is going to increase the risk of adverse outcomes. The MINT trial is a specific trial in 2023 that included a lot of patients that had type 1 and type 2 myocardial infarction, and they also looked into 2 thresholds, either transfusion blood 7 or 8 and below, or having a cutoff of 10 or even greater, a more liberal strategy, and then they looked into the 2 different strategies and they found that 30-day mortality in the restrictive group compared to the permissive group, it was not statistically significant. Okay, the cardiac death rates in the restrictive and permissible group, there was actually a difference between those 2 groups. So what I'm trying to say is that within this group, we might be more liberal than others, especially if there's a cardiac component. Cardiac surgery, coronary artery bypass, graft, valvular surgery, or both. What would be the recommendations in this population? If you look into the CHEST 2024, they have a paragraph talking about that. In critically ill patient undergoing cardiac surgery, they suggest a restrictive over permissible or permissive transfusion strategy. And the recommendation is actually conditional. They looked into 3 studies, and they looked into 30-day mortality, and they said that there was no significant difference. And that's why when we look into a critically ill patient that is going to go for a cardiac type of surgery, we still do the restrictive strategy in this patient. Okay, we see a few cases that have isolated elevation in serum troponin. They don't necessarily have myocardial infarction, and obviously there's a lot of reasons for why we have that increase in serum troponin. Should we be concerned? Should we consider them as an ACS patient? Should we be more liberal with hemoglobin? And if you look, there's not a lot of studies that look into that. However, I was really happy to see that just review of the 2024, they looked into it and they said, and this is their recommendation, in critically ill patients with isolated elevation of serum troponin without other evidence of cardiac ischemia, that they would suggest a restrictive over a permissive or liberal transfusion strategy. And I have the quote from from the guide itself. Troponin level represent a test value rather than a specific clinical diagnosis, particularly in critically ill patients in whom elevated troponin levels may be indicated for diverse conditions that are unrelated to ACS. So I find that interesting because we see that a lot in practice, and then we tend to see, okay, should I consider it, should I think about the liberal or the restricted transfusion strategy? If you look into the document, you see a really nice algorithm or a guide that look into a critically ill patient that came with different types of scenarios and what would be our recommendation if we want to follow a threshold of 9 to 8 for hemoglobin or less than 7. 15 minutes, right? Okay, TBI patients, they didn't talk about that in that document. A lot of the guidelines or a lot of the evidence is really separating TBI from the general type of patients because there's a lot of talk around that. The recommendation RBC transfusion is considered for TBI patients with a hemoglobin of less than 9. What are your thoughts on that? Would you agree or not? Do you have a different practice or a different thought?
So we don't have documentation, but general thing in brain is being good oxygen.
Exactly. So this is the thought process. But do you follow a certain number? No. So this is what I found into the literature because I've seen a lot of differences sometimes between guideline to guideline, but this was the most common number that I would see. TBI, you don't think about the 7, you think about the 9. ACS, you think about maybe also a 9. Okay. If I found this thing also in a very nice document summarizing the different types of guidelines, whether European or American, and they looked into the different indication, whether trauma, septic shock, acute bleeding, non-bleeding patients, heart disease patients, patient undergoing cardiac surgery, which is just what we've also talked about, okay? And I loved how they summarized each one and what type of RBC thresholds that they would recommend. So we do have it in general, you can see that they all are straight about the 7, but some of them would say below 7 is one that some of them would say if you're at 7, this is when you would recommend the transfusion. And then you see them into the different types of cases, what would be the different threshold. And again, they all have the same opinion about patients who have heart disease, that the threshold is going to be more liberal. Okay. How about now we're going to talk about active hemorrhage. Again, if it's either a 7 to 8 in most of the cases as well, or 9 to 10 in certain patients who are hemodynamically unstable and that require transfusion. That's something that we do regularly and we don't really need that much thought into it. But if you wanted to see it based on evidence, it would be that restrictive transfusion are typically not recommended in the case of an active hemorrhage, especially if there's hemodynamic instability as well. And the liberal transfusion are often necessary to ensure adequate oxygenation to prevent shock while also considering fluid resuscitation. And unfortunately, that's something that we see a lot, is that we give a lot of fluids, crystalloids and whatnot, and because we don't really have regular supply of whole blood or blood products. Okay, I know we talked about reversible agents with DOACs and DOACs-associated bleeding, and I told you that we're going to talk about blood products in the context of DOAC-associated bleeding. Is it going to be different than our usual cases or not? So RBC transfusion may be required in these scenarios or these cases. It really depends about the condition itself. If the patient is actively bleeding, how much is it bleeding, how severe is it bleeding? And then we think about platelets, if there's thrombocytopenia, so it's not really different from our usual case scenarios. We think about plasma, cryo, even 5/7. There's not a lot of evidence to support its use in the setting of DOAC-associated bleeding. Okay, there's actually higher risk associated with them, except in situations where we said that there is coexisting coagulopathy, for example, dilution of coagulopathy, VIC, trauma, and things like that. So if the patient has a DOAC on board and the patient is actively bleeding, it's not going to be any different from a patient that's not on these agents. Now let's talk about hemorrhagic shock. So before we start, I want to know what's your practice, patients actively bleeding severely, and now they're in hemorrhagic shock. What would you do? What's your approach? What would be the first thing that you do?
Good early lines.
Okay, see, everyone talks about from their perspective. I like that. Okay, lines, if they're not there, yes.
Yeah, start with managing the short space.
Okay, that's what I wanted to hear. Even though we want blood, we still start with crystalloids at the very beginning, okay? But the thing is what are the consequences of giving a lot of crystalloid in a patient that lost a lot of blood? Dilution of blood will happen. So what we're trying to say is that if you have loss in blood, then you prefer giving blood. And I think over the years we got better in terms of not giving the patient a lot of crystalloid and really focusing on giving blood
We
products.
do cross matching or we do five specific products.
How long does that take? Hours.
Cross matching.
So when you want blood,
That's much 15 to 30 minutes.
that's why, because I heard a lot of
If you
things.
have blood bank, it's okay,
Yes.
but if you are ordering from
We
outside,
don't have a,
if your hospital is good, yes.
yes,
But your
there is
hospital-
emergency release of non-matched.
But you don't have blood bank, so you
Which
order
hospital
from
you are
outside. Yeah.
When I put this together, I asked a lot of, my colleagues, and I wanted to see what their practice in different settings, and I was shocked. And they were like, don't ask a lot of questions because the more you ask, the more you're going to be shocked about how, fast we can get blood products for our patients. Yeah.
Products should be prepared ahead.
We say that, yeah, I just love that to happen, but unfortunately, that's
For
not the
emergency,
case.
they can take the blood on spot if they sign emergency release.
Yeah,
So
but
without
unfortunately,
cross-matching.
yes, with reversal,
Sometimes
and
take time.
Takes time.
yeah, but I think a lot of places, they still struggle with getting it on time, and there's a lot of process to do. Okay, so are you aware about the Advanced Trauma Life Support Guidelines for Hemorrhagic Shock, and that we have 4 classes of hemorrhagic shock? Has anyone come across this before? So we have basically 4 classes. At the beginning, where we have a patient that's bleeding, the amount of blood volume, let's say if they lose 15% or less, then that's class 1. And the more they lose blood, and the more there's hemodynamic instability, and the more there's alteration of the status, urine output, and all that, then the worse the patient is at, and then we reach a situation where we want to activate the transfusion protocol. So what we're concerned more about is losing 25% or greater of blood supply, and this is when we go into the class A and class 4 categories. Hemostatic resuscitation with whole blood or balanced obviously blood products. And the goal really is replacing the loss of blood volume while also trying to keep the coagulopathy that would happen. As we mentioned, we lose blood, we want to replace it with blood. Mortality rates over time has improved. If you look into the literature, before it was really 50 to 80% mortality rate. Now it's actually close to 10 or 10 to 20 over the last years. Sometimes we talk about massive transfusion where we give a lot of blood, and sometimes we talk about massive transfusion protocol, which is something standardized or a protocolized way of giving it. And it really was based on the 2015 PROPER trial, also an RCT, one of the landmark trials that looked into the different ratios of different blood products, and based on that, they looked into any type of differences in mortality. And the easy way of just summarizing it is if we give these drug products and a 1-to-1-to-1 ratio of plasma platelets and RBCs, then it would have a better outcome than having it in a ratio of 1-to-1-to-2 units of RBCs. So when you look into this trial, they looked into 24-hour mortality, they looked into 30-day mortality, and they found that there was no difference whether we give it in a 1-to-1-to-1 ratio or a 1-to-1-to-2 ratio. However, the 1-to-1-to-1 ratio had better collection of coagulopathy and reduced blood loss, and this is why we tend to talk about the balanced protocol that has improved outcomes. So this is just, what we mentioned, the massive transfusion protocol, balanced transfusion. The purpose of it is to prevent and avoid dilution of coagulopathy. We give the different blood products in fixed ratio. I wanted to know, because I've asked this also outside, how is this implemented? And is it implemented or not? Or do you just think about whole blood and that's what's available? Do you actually activate this and do you actually do it in a fixed ratio? And how easy is it done from your practice? Not easy. Yeah. It's easy said, but not done. Right?
It's written, but
It's-
not to follow it.
Yeah.
Because we
Yeah.
need to educate all of the hospital workers, not only the physician or the nurses or the frontline. Because it's a cooperative process between who's ordering, who's attending physician, who's preparing payments, and how to put the package all together.
Exactly.
One to one to one. Is the units available in hospital or we need to bring it from the central blood bank?
Yeah.
So easy to write.
Yes, easy to write. Sometimes there are hospital teams that would be part of that, to activate within the hospital. Exactly, even the person that's transferring, yes. So I can see that a lot of people that are involved should be educated and should know because they play a part into making this successful. So yes, I've seen it in theory. Unfortunately, in this part of the world, I don't see it really being
We have
implemented.
implemented in our hospital and we apply it for 2 patients now successfully.
Oh, wonderful. Okay. I was wanting to hear that this is the usual practice in most of the hospitals, but I was shocked that it's not. Yeah. Okay. Is it validated? Yes, it is validated, but this protocol is validated in traumatic hemorrhage, not in other types of scenarios, for example, obstetric or operative or GI-related hemorrhage, but we still tend to use it within the hospital setting. So this was the question, do you use it in the process of doing it? And I can see either you were quiet, that means you don't use it, or you don't practice it, or you don't know, or it was done relatively based on your specialty. Okay. When you think about blood resuscitation, you think about, okay, when would I think about blood resuscitation? It depends on the patient, how stable they are or not, how rapidly are they bleeding, what is the trajectory of bleeding itself, and is the patient in hemorrhagic shock or not. There are other types of scenarios or other things or questions that you might have also in mind. If you want to go by the book or by guidelines or by the literature and you want to see when should I activate the massive transfusion protocol, you see that severe blood losses, where there is 50% blood losses within a very short period of time of 3 to 4 hours, or if you're losing 150 mLs per minute within 15 minutes, of blood loss in patients who are hemodynamically unstable and still have suspected or ongoing bleeding, in patient that has a trauma with an uncontrolled hemorrhage, in patient that has coagulopathy in a setting of bleeding, and that would be notified based on the patient's INR, fibrinogen, platelet levels. These are certain scenarios or cases where I would think about activating the massive transfusion protocol. Okay, I'm almost at the end, because I think we need to take a break right now according to the schedule. TXA, do you use it? Because we haven't talked about this throughout my talk today. I think it's worth just bringing it up. That's another talk for another time, but I just wanted to catch your thoughts about when do you think about using it.
Yeah, prophylactic.
Okay. Prophylactically, surgically, okay. Any other scenarios, cases where you want to think about it? Potentially, yeah.
What would be massive transfusion?
Oh, let me hear both.
Post-operative, okay.
Yes, post-operative, okay. Yes. What was your comment?
After PCCs, surgery,
It was operative, yes, yes, exactly.
But the massive transfusion of blood we are using.
Yes,
So we have stop the bleeding
Yes.
after the surgeon or intervention.
takes place, yes, okay. So I love your answers, everyone knows where to use it in different settings. Of course, there's a lot of multiple uses and a lot of different dosing also and how to use it. And unfortunately, we don't really have enough time to talk about the different dosing and different cases of when you want to use it or not. I just wanted to bring it up just for completeness. There's a lot of trials and recommendations around it. If you look into the CRASH 3 trial of 2019, the WHO recommendation, they would say in patients that early TXA administration within 3 hours of an injury in traumatic patients, that would reduce mortality, and that's why they would recommend using it in these types of situations. If you look into the European 2023 guidelines, they strongly do not recommend using TBI outside of the TXA outside of the TBI setting. The American College of Surgeons, they discuss TXA use in hemorrhagic shock. They do not have any specific recommendation for using it. So we say that we have different dosing to it, and skip that. And then the last part is calcium. Do you think about calcium when you think about transfusion blood, especially the aggressive transfusion blood?
After 2 minutes,
After what?
2 minutes.
After 2 units. Okay, so I see that there's a guide here that you have standardized. Okay, not necessarily 2 units of what, RBCs?
Yeah, there's blood.
Is that regular practice?
It's not regular, but just.
It's based on your knowledge.
This is old knowledge.
Oh, yeah, but it's nice that you have that behind your back. Because a lot of people, when it comes to calcium, not everyone is well versed about the need for calcium.
Because
And then,
of citrate.
yes, exactly. Yes, because blood products contain citrate, it will bind to calcium, so it will lower the level of calcium. So I just wanted to bring it up really quickly. Calcium is really important because it activates platelets, it activates circulating clotting factors, so it's part of the coagulation cascade, let's say, and at the same time it has a role definitely within the body for cardiac, right?
With everything else also.
Exactly, cardiac situations, exactly. Okay. Before, when we talk about trauma patients, we talk about let's say the triangle, we talk about acidosis, coagulopathy, hypothermia, all of these have a close relation, or when we think about severity and mortality and worst outcomes when we look into acidosis, coagulopathy, and hypothermia. And one of the things that are now added according to recent studies is hypocalcemia, because the higher we have hypocalcemia, we have impaired clotting formation, and that can also worsen the outcome in trauma patients that require transfusion. Okay, we talked about that. The recommendation, according to the Joint Trauma System Guideline, 1 gram of calcium immediately after the first unit of blood, and then within every 4 units ongoing resuscitation. So I like, if 2 units is fine, 1 unit is fine. Maybe some people don't think about calcium as well, but I like that there's a guide, to tell you that you have to think about calcium and you might want to replace it. And if I had more time, I would have used maybe hours talking about the literature around what's the best amount, what's the best type of replacement, when should you think about it, different types of perspective, but because of lack of time, I just wanted to make sure that you think about it when you think about blood transfusion. So I think that by that, I would finish my part. I do have few cases, but we don't really have to. It's like 2 or 3 cases. Whoever wants the slide deck, I'm happy to share it with all of you, because sometimes, a few hours is not enough to capture everything, and you just want it as a resource. I tried my best to put the guidelines that I refer to as well, so it makes it easier for you to go and read the actual guides or the studies that I've included. If I had more time, I would have maybe added so much more. This is why I told you we have a few hours. I want to talk about a lot of things. We have another guest that has a nice talk as well. So hopefully you got from it, and I'm going to be available till the end to answer all of your
I
questions.
would like to share through maybe to organizers, our phone number so they can send.
I'll make sure that they do that. I'll follow up, and I'll make sure, and I appreciate your time. Again, I'm going to still be here just because we have our break time. So we can do maybe 10 minutes. And again, I'm not really sure about this arrangement of don't go out with other people, so just get your snack, whatever you need, and you can just rest here and enjoy your snacks and drinks over here. Okay?